Great. All right. Welcome everybody to our fourth presentation on dysautonomia. Today we're going to talk about how to manage neurogenic orthostatic hypotension. My name is Nancy Barlow. I'm the wellness coordinator with Parkinson's Resources of Oregon. I always like to make sure that you know that PRO has been serving Oregon and Southwest Washington for the last 40 years. We provide education, advocacy services, support services, exercise classes, and wellness services as well. So we're happy to be doing this series. We're happy to have Jean with us here today. If you read her bio when you signed up on our Eventbrite, then you're aware of some of her credentials. Jean is a retired nurse, and she also has her PhD. But I'm going to tell you just a little briefly about Jean. Jean stopped working as a nurse when she was diagnosed with Parkinson's, and she's had quite a journey. For the last 8 years, she's had a lot of symptoms that she just hasn't been able to find the answers to. She's been sent to cardiologists, to pulmonologists, to the neurologists, back to her primary care physicians, and she's done that circle multiple times over an 8-year journey. And she kind of went back to her roots, being frustrated with not finding the answers to these things. And so she started digging through research articles, which she's trying to know how to read and know if they're legitimate. And she landed with Dr. Goldstein, who did our first 2 presentations from the National Institutes of Health. And she was finally diagnosed with dysautonomia, neurogenic orthostatic hypotension. So through this, I think she's read hundreds of research articles, honestly. Easily, yeah. So she, by just trade, she is an educator, and she is extremely motivated to share her knowledge and educate people with Parkinson's, and also physicians on what dysautonomia is, because a lot of people, we don't know what it is. So she's kind of just starting her mission. And we're really happy to have her here today. So welcome, Jean, and I'm going to let Jean take over.
Thank you. I'm find my talk and see if we can get it up. There we go. Well, thank you very much, Nancy, for that introduction. And I really appreciate the opportunity to share with you some of what I've learned in the last year of researching. The talk today is entitled, "Do you have Parkinson's deadly, disabling, non-motor disorder, neurogenic orthostatic hypotension?" So you probably think I'm exaggerating, and I wish I were, but I'm not exaggerating. Is it on? We might be having technical difficulties.
Everything looks good as far as I can tell.
Okay, so
Okay,
you're
then.
seeing her slides.
Oh, I was, then they went away. Okay.
Okay.
How about now? Can you see it now?
I think you're gonna have to reshare because there was something that happened and then yours went away.
If I reshare, what does that mean?
Select it again. Go to share screen and select it again.
Go to
That
Jean.
the green share
There.
screen on the bottom center.
Here we go. We got it. I think so. Hang on. Click it. Did it?
Okay. And then go from beginning again. There we go. Now we see it. We're good.
All right. Can you hear me?
Yes.
You know where I left off? So start at the beginning with the title of the talk. I assume
Okay.
everybody is here.
We could hear you. We
Okay.
just weren't taking the slides anymore.
Okay. I'm not sure what happened, but I'm glad to have you all back. I assume you're back. So the question we're going to address today is, do you have Parkinson's? Part of Parkinson's disease is neurogenic orthostatic hypotension. And about half of people with Parkinson's have it. And we want you to find out if you are one of those half. So that's a big part of what we're going to talk about. And I want to clarify some terms before we begin so you don't get lost. The one term that is probably most important to remember is dysautonomia, which merely means it's a disorder of the autonomic nervous system. So the number two is, what's that? Well, the autonomic nervous system is part of the peripheral nervous system that operates automatically, such as breathing, heart rate, your eye blinks, constriction of your pupils or dilation. And it has three types of nerves in it: sympathetic nerves, which are like the fight or flight nerves, that if you have to give a talk and you get nervous, that's your sympathetic nerves that are kicking in. Parasympathetic and enteric, which have to do with your bowels. Okay, so what dysautonomia is, there's something wrong with your nerves that innervate your heart, your brain, your breathing, your heart rate, your eye blinks, etc. So how does that relate to neurogenic orthostatic hypotension? Obviously, neurogenic means it comes from the nerves. So that is a form of dysautonomia where the blood pressure falls at least a certain amount, 20 millimeters of mercury systolic, which is the high number, and it falls at least 10 millimeters of mercury diastolic, the low level, when you stand up after lying down. This disease, neurogenic orthostatic hypotension, is serious and it's chronic. Once you have it, it doesn't go away. And it's caused by a disruption in the autonomic nervous system. And that is to be differentiated from orthostatic hypotension, which sounds very similar, except it is not of neurogenic origin. It's caused by things like dehydration, decreased blood volume, vomiting, for example, can do it, not drinking enough water. It's easily and quickly cured. Orthostatic hypotension. Neurogenic orthostatic hypotension is not easily cured. It is not cured. It's chronic and there is no cure. Okay. And these two terms I want to make sure you remember: hypertension, which means your blood pressure is high; hypo, our blood pressure is low. So in this case, neurogenic orthostatic hypotension, we're talking about blood pressure that falls and is very low. Okay. Next, I can't read my slide. Okay. So NOH, I'll just call it NOH. It's very common. Let's see. I'm sorry, I went way past environment. Okay, neurogenic orthostatic hypotension is very common. It's important to remember that. And these 3 points are my thesis. It's not on the top of the screen here, but what I'm arguing is 3 points. First of all, we know it's very common. It is not that is a fact. It is a non-motor Parkinson's disorder, which greatly increases our risk of severe disability or death. The second point I want to make today is this disorder is poorly understood by most doctors and most patients. And educating patients who have this disorder, educating us to recognize its signs and symptoms and how to keep a log of what your standing blood pressure at home is, and through a 24-hour ambulatory blood pressure reading, can assist patients in reducing the impact of this disorder on them and in promoting better communication with your doctors and with this poorly recognized disease. So my 3 points are right here, and we're going to talk about that. So let me start off by comparing some little background information that will help to understand. Oops. Okay, understanding the difference between these two. I said before, neurogenic is by the autonomic nervous system. It's serious, chronic, debilitating, and it causes damage to the brain, heart, eyes, kidneys, etc., to the length of time that it's affecting the body, but it's not recognized. I'm sure you're familiar with hypertension, which they call it the secret killer or the hidden killer, because it's gradually destroying parts of our bodies while the blood pressure is very high, but we don't have symptoms. This is a comparable physiological event. It's explained very differently, but the same sort of phenomenon is occurring. We're having problems that we don't see right now, and eventually they're going to do damage to our target organs, they call them. In Parkinson's, it's caused by the disorder of the autonomic nervous system, the loss of postganglionic sympathetic nerves in the heart. That's the transmitter is norepinephrine. So because we're losing norepinephrine in our heart, we are having these symptoms. But then we may not have any symptoms. And that's part of the irony of this particular disease. The only way to determine if you have it is to take one's blood pressure, not normally like we do sitting up, but lying down. And we would follow that by standing up. So you take a comparison blood pressure, which is why I said earlier, if it drops 20 millimeters of mercury, that's where you see the difference from what it was before to what it is stand up. It's very easily tested if you do that test. But most doctors, most clinicians seldom take that test. There is no cure.
How are you doing? You're good. Do you have any problem with the plumbing?
Who is that? Somebody needs to mute themselves.
Oh, yeah.
Okay. Okay. So that's the neurogenic.
But Suichi,
Yeah.
you need to mute
Yeah,
your
my house
device.
was built in 1952, so it's been old. So I don't know. I need to figure out my plumbing system too.
So,
Okay. Can you get it muted? Okay, looks all right.
Okay. The other kind of neurogenic, non-neurogenic orthostatic hypotension, which is just called orthostatic hypotension, is also very common. In fact, it's one of the most common problems the elderly come into the emergency room with. So doctors are very familiar with seeing orthostatic hypotension. They're not very familiar with seeing neurogenic orthostatic hypotension. And the non-neurogenic OH is easily identified, and it is due to what I mentioned earlier. We're trying to get this to go off. There we go. It's caused by a lack of volume in your bloodstream. So diarrhea, not drinking enough water. And certain medications can, including levodopa or antihypertensive medications, can contribute to causing you to have OH, but not the dangerous kind. It often is accompanied by symptoms of dizziness, and the history is the only diagnostic tool that is used by most doctors. They just ask about the person's, how much you've been drinking, et cetera, to determine. Again, you seldom see anyone take the blood pressure in an orthostatic standing position. And this OH is easily corrected. It's not a chronic long-term disease. It's easily corrected by removing the identified cause. If you need to drink water, cure the diarrhea, and see if you can switch to a different medication. So causes, for one, are very permanent, chronic, serious, and for the other, it's very easy to identify and easy to fix. But the other thing I should mention is it's very common to have both at the same time, and that confuses a lot of clinicians. Okay. Factors. Why are clinicians confused? Well, the overlap in symptoms, as I just mentioned, is difficult to distinguish when you're not familiar with the neurogenic. Another reason is, I know this sounds hard to believe, physicians have never been exposed to dysautonomia in their medical school classes during their residencies or fellowship education. It's been this discovery of dysautonomia's influence on Parkinson's is relatively new, and it really hasn't infiltrated the infrastructure for medical school education. Okay, and lastly, this is what I'm alluding to. There's been a paradigm shift, a shift in the whole belief system of what causes Parkinson's in the last 25 years due to discoveries. So most medical schools and academic healthcare centers have not yet incorporated this perspective into their Parkinson's paradigm, the way they think of Parkinson's. Okay. And this just explains a little bit about that. It's a quote from one of the researchers. She says, Parkinson's disease is broadly known to be a movement disorder, right? We're all familiar with that. Most of our doctors are movement disorder specialists. So it originates, that disorder, which we all have, originates from the reduction of dopamine in our brains because of the nigrostriatal system. It doesn't have enough dopamine. It has a profound lack of it. And also the presence of alpha-synuclein or Lewy bodies. Well, this author also says, developed more than 50 years ago, this definition, based on the brain condition, is no longer an accurate description for Parkinson's. Numerous studies have shown that clinical manifestations of the disease go well beyond the motor system and set up a complex scenario in which non-motor symptoms appear even years before the motor ones. So quite often, non-motor symptoms will appear before the movement disorder shows up. And this is a quote from Dr. Goldstein, who spoke to us 2 months ago or so, from the National Institutes of Health. Despite the fact that dysautonomias affect over 1 million Americans, you will probably find that very few people and surprisingly few doctors have ever heard of dysautonomias. It may be that no doctors in your area specialize in treating autonomic disorders. And in fact, I tried to find a list of doctors in Oregon and Washington and California who are certified in dysautonomias, or that's just the title of their subspecialty, autonomic medicine. And there are 0 doctors certified in Oregon. There's 1 in Washington State and 3 in California. So he speaks the truth. Others can learn about it, but they're not certified. Okay, so what is NOH and how does it relate to Parkinson's? I'm just going to briefly go over this because I think many of you know this. Parkinson's is known as having 2 types of symptoms, motor symptoms and non-motor. And among the non-motor are cognitive issues, psychological fatigue, hallucinations, etc. But what we're talking about is, go back there. We're talking about this one down here, orthostatic hypotension, which can cause lightheadedness. So there's 2 categories of symptoms. And I wish I could see the slide. One, dysautonomias are a form of non-motor Parkinson's. There's many others, but one whole category, as you can see, this is a description of the dysautonomia problems throughout the body that can show up in Parkinson's. We're just talking today about this one type of problem, but if you have, I have pupil problems. Do we have saliva? Are our eyes dry? Gastrointestinal problems. All of these are caused by dysautonomias. I used to think that these problems were random and kind of, how do they hang together? We've come a long way in understanding that they are in fact related to the fact that we have problems with our autonomic nervous system if you have Parkinson's. So here's another author, Stubendorf, who says non-motor symptoms like ANS, autonomic nervous system dysfunction, are considered by many patients to be more disabling than the motor symptoms. Despite this, they are often poorly recognized, inadequately treated, in contrast to the motor symptoms. So much of the research that's going on now is focused on motor symptoms, but not nearly as much as looking at autonomic nervous system. That helps to explain why we don't hear about it that much. Well, how common is it? Orthostatic hypotension, a fall in blood pressure when the PD patient stands up, occurs in 30 to 40, I've seen it as high as 68% of patients with Parkinson's. Well, why don't we know exactly? The studies all vary depending on exactly who is in their population. If it's a nursing home population, it's a very high percentage. If it's a random population of individuals with Parkinson's, it's more in the 30 to 50 range. Oh, let's see. I got a trigger finger here. Okay. If a clinician depends on asking for symptoms or signs, like, do you feel dizzy? Do you feel lightheaded? If they rely on that before they measure the blood pressure, the orthostatic blood pressure, they're going to underestimate, because usually with orthostatic hypotension feels nothing wrong, or they have symptoms that are non-specific when they're upright. Let's take a look at some of these. Fatigue when standing. Well, you might not think necessarily it's due to low blood pressure, but it might well be. That's one of my most common symptoms. Difficulty walking. I just can't walk the dog anymore. It's too stressful, too taxing. My vision is very blurry much of the time. And I have pain running across my shoulders. They call it coat hanger pain. Confused, inability to think clearly. Yes. In fact, what I play a game, I realize with myself. I tell myself, oh, I don't want to think about that now. But what I mean is, I can't think about that right now. Feeling faint. I've never fainted. And difficulty breathing. This was the symptom that I most exhibited for 8 years, and none of the doctors could diagnose it. They thought it was cardiac in origin or pulmonary, but nobody, until I went to NIH a year ago, recognized that the difficulty breathing had to do with the difficulty of circulation getting up to my head because of my low blood pressure. So NOH is one of the most debilitating non-motor disorders in Parkinson's. And this slide, if you remember nothing else, I want you to pay attention to. This one is frightening, frankly. It carries 3 times the risk of early death compared to PD patients without this disorder. So early death, none of the other non-motor symptoms, all that picture of the human body with any of these others, they look to see, do any of them have to do with loss of life or disorder, early death, and they don't. So it's the only one of the non-motor categories that is associated with survival. The incidence among even brand new Parkinson's patients is high. You don't have to have had it 10 years like I did to come out with these symptoms. In fact, they often appear prodromally before there are any symptoms at all of motor symptoms of Parkinson's. Other long-term consequences are stroke, higher incidence, heart failure, 7 times the risk of dementia, 7 times, atrial fibrillation. All of these are related to death and disability. 5 times the risk of falls and head trauma associated with hospitalization due to low blood pressure. This is just outlining some of the impact that it has on the heart. And because I mentioned that, the chronic nature of this disorder, we have it for years. I had it for 8 years before it was diagnosed. The chronic nature of it allows remarkable adaptive changes in our cerebral autoregulatory mechanisms. In other words, our brain has gotten used to having so little blood that it has adapted, and we no longer feel like we're going to faint, even when it's extremely low, and maybe our spouse or friends who had it that level would faint immediately. But this is part of the scary feature. You can have extremely low blood pressure from neurogenic orthostatic hypotension, and you have no idea. You don't know that your blood pressure is extremely low. And when your blood pressure to your brain is extremely low, what happens? Well, your brain suffers because it doesn't have the oxygen. That's why you get confused. That's why you feel weak. You feel unable to move. And it also does damage to your brain. And indeed, it was rather stunning to me when I saw my brain scan, Dr. Goldstein did last spring, and it was frightening when the report came back with damage and a lot of white matter hyperintensities, which is a classic example of brain damage that often is associated with dementia. So beware, this is a frightening disease. Patients are able to tolerate wide swings in blood pressure and remain conscious at pressures that would otherwise induce syncope, fainting in healthy subjects. So this is really a frightening disease. What to do for patients? Oh yeah, didn't mention this. There's another common accompanying disorder called supine hypertension. Those of us who have neurogenic orthostatic hypotension, NOH, also quite often between 50 and 98% of the time. So over half of us who have this also have, ironically, when we lie down, our blood pressure is high, supine hypertension. So if you stand up, it falls low. When you lie down, it's too high. In fact, tell you a true story. Last week, I went to the emergency room at 4 in the morning because I woke up with tightness in my chest. My blood pressure was 190 over 130. Supine hypertension. I had no symptoms other than the tightness in my chest, which thank God went away. So the management, this is what this researcher says, the management of supine hypertension in patients with orthostatic hypotension is one of the most difficult scenarios in clinical medicine with no solutions in sight. They gave me no medication. They didn't know what to say, except these things happen. So it's frightening. Here is a visual image of what's going on in our hearts. I said we lack the neurotransmitter norepinephrine. So in the initial evaluation, this is a scan of a patient's heart with Parkinson's, but who did not have a lack of the norepinephrine at that stage. But you can see this, they repeated the scans over the next several years. And after 6 years, there was almost no visibility from this radioactive dye they inserted. And it was showing the sympathetic nerves. This dye attaches to the sympathetic nerves. And by 6 years, there was none left. This is a picture of a scan, oops. A scan of mine. Let's try again. There. Okay, here is a picture of my heart, and you can see my liver, which is bright with sympathetic nerves. This picture was taken, a scan was taken a year ago. I had no sympathetic nerves left in my heart. And you go, well, surely you're going to die. You can't live without that. Amazingly, we don't know that much about it. You obviously can live, but it's a challenge when your body is stressed, because the sympathetic nerves are what helps your heart to constrict when you walk up a hill, you start exercising. And if your sympathetic nerves don't tell your heart to constrict, or there's no sympathetic nerves there, it can't constrict like it's supposed to. It can't pump the blood up to your brain. And therefore you have shortness of breath like I do, or some of those other symptoms. So, so what do we do about this? We're nervous, I'm nervous, but I think the important thing is, what can we do I feel like I want to use this knowledge to help us advance our situation. And I think educating each of us with Parkinson's about NOH can help. And how so? Well, if we take our home blood pressure, then that'll help promote a conversation with our clinicians and help reduce your symptoms. Because if you know you have this problem, we're going to discuss today some of the interventions you can do to help minimize the strain on your brain without having enough oxygen and blood in it. So I really find this an inspirational image that gives me, it conveys a sense of my philosophy. There's this scientist in Sweden called Sarah Rigari, and she made this image up where it talks about, she happens to have Parkinson's. And she says, this is a picture of a year, all the hours that are existing in a year. And she says, out of all those hours, I spend 1 hour with my clinician in neurological health care. And she spends 8,765 hours in that year taking care of her own symptoms and problems with neurology. So I think that's a really important thing to keep in mind. We're basically responsible for ourselves. And it's up to us to take the initiative to find out what's going on, ask the appropriate questions, and work as a team with our physicians to make sure our questions are answered. So I want to show you a video on how to take your own orthostatic hypotension measurement. And we're going to start it now, I think.
She's working on it. There it goes, there it goes.
Okay, did you want to say anything before I press play?
Yes, I was just going to say, this is a very short video that explains how you can take your own blood pressure. And I think I've given enough background why I think it's important that we be able to tell that if we have it or not, have this disorder or not, because our physicians often, or very few physicians ever take our blood pressures, our orthostatic blood pressures. Okay, so go ahead.
Okay.
Thank
And
you.
when I play it, it's as loud as it goes, so you can turn it up on your end. So
Okay, thank you.
Welcome to our demonstration on how to take an orthostatic blood pressure. It's a very simple process, and I'm going to make it even simpler by using an automatic electronic device that will measure my blood pressure and pulse very accurately and very easily. So before we begin, I just want to remind you that when you do your orthostatic blood pressure, you should not have just eaten a big meal. Maybe snacks are fine. And you don't want to have just had alcohol. That too can make your blood pressure fall. You do want to hold still through the process, so you don't cross your legs, you don't laugh, talk, etc. And lastly, you want to make sure you have on a short sleeve shirt so that you can measure your blood pressure without interference from your clothing. So what we'll do is 2 steps. First, we'll take your blood pressure line, my blood pressure line, and then we'll do it standing. And we'll see the impact that gravity has on our arteries and on the success of our body in responding to the standing position. Okay, so let me start. Now, when you lie down, you want to lie flat if you can tolerate it. If you cannot, that's okay. We want you to be comfortable and be able to get enough oxygen by having your head raised if you need that. And we're going to put our hand right next to our leg, and it's supposed to be, the cuff is supposed to be at the level of your heart, and it is right here. So we push the button to start, and then we just lie here and wait for it to beep or finish whatever it does, and you'll be able to tell when it's finished. So let's say it's finished now. I get up and I go as quickly as possible to a standing position. And I'm going to stand right here where I can rest my arm on something. It won't be dependent, hanging down, but it'll be resting on either the machine or the top of the sofa. And I'll stand this time. And you're supposed to try to get your blood pressure taken as quickly as possible after moving from a lying position. You don't have to wait a whole minute. You push the button to stop talking, and you get the reading. And then we have a sheet where we're recording the heart rate as well as the blood pressure, first lying and now standing. We have 2 more minutes to wait because we want to get our last reading as a standing position after about 3 minutes. So we record everything, and then we have not just have we taken it, but we can discuss it with our physician or with a nurse or with other friends and family. So 3 minutes is up. We'll take it a second time. Push the start. Support our arm. No talking. We take it again. And then what? We record it again. So what we have at the end are 3 different recordings. The diastolic, which is the low number of the blood pressure when the heart is at rest, and the systolic, the high number, for 3 different positions: lying, standing, 1 minute, standing 3 minutes. We can also put in comments whichever medications we might be on for blood pressure, or if we got dizzy, we could put down something relevant to that. So I hope you have enjoyed this little presentation. Good luck to you.
Thank you. Okay, so this is an example of the recording sheet that I used, and I hope the demonstration explained this, the method very simply. There's also the possibility of a 24-hour ambulatory blood pressure monitoring, in which you wear a cuff all day and night, and you carry this blood pressure machine around with you. My hope is that you would start off measuring your own blood pressure to determine if you even have a problem. You may not have a problem, but if you're part of that 1/3 to 1/2 of Parkinson's patients who do have orthostatic hypotension, and you want to know it, which I think most of us would, then the taking it at home is a very good place to start, and a great way to bring that into your physician and ask questions about what do you think would be the appropriate next step. Maybe you have a cardiac problem. Maybe you don't have orthostatic hypotension at all, but or you have that in conjunction with some other disorder. So you're not diagnosing yourself, but you're at least documenting a significant concern. And then based on that conversation, he and you, she and you may wish to have a 24-hour blood pressure reading to find out how does your blood pressure look during the day, and do you have a problem at night, like many of us, most of us who have orthostatic hypertension also have supine hypertension. So that would help to discover it. And then you could, have that as a document to take with you to your doctors. There's also research indicating who should be routinely screened for orthostatic hypotension. And while it's not currently being done, more commonly, you're finding researchers say anybody, including anybody with PD, should be having this routinely screened every time you go to your physician. And at this point, I would ask you if you might want to consider asking your medical assistant or your doctor probably first, should you not have, at least could you have a blood pressure taken lying and standing? And again, you lie for about 5 minutes, rest, and then stand. So you can start however you wish, but I think it's important to recognize that this is an area that is becoming more routine than it ever has. So enough about the background of the orthostatic hypertension. Let's talk a little bit about preventing, more practical interventions. Things that we should be aware of is when we do stand up, if you suspect you may have this, stand up slowly. My sister told me when she came to visit, you always jump up, you don't get up slowly. And I'm thinking, yeah, you're probably right. It's not smart, especially if you've been resting for a long time. And you might just want to, when you go from the lying position to the standing position, you might want to just rest for a second or two or three in a sitting position before standing up. Another thing, practically, avoid heat exposure. Prolonged standing, like in the grocery line or shopping, I find that most difficult. Alcohol causes your blood vessels to dilate, and that also causes your blood pressure to fall. Large carbohydrate-rich meals, again, same thing. They cause your blood to pool in your abdominal area. Valsalva-like maneuvers, that is like compression, like with stool pressing down, that's really dangerous because that causes the blood flow to the right atrium to diminish. Daily routine adaptations like showering, sit on the chair perhaps, or for male patients, Dr. Goldstein was quick to not advertise, but to give advice that men should never stand at night when they void, because that could well again cause them to have a fainting episode. So these are some of the preventive things. If you find you have symptoms, you might want to sit or lie down. Even if you're in the grocery store, I just find a place to sit. I've even sat on the floor at times. That's one thing you can do. Other activities is to step in place, just like we do with our exercises with Nancy. Just start walking or marching. Cross your legs and bear down. Tense up the gluteal and the abdominal muscles. My husband always told me that when I was about to get lightheaded. He'd say, squeeze your butt, squeeze your butt. Or bending forward gets more blood to your brain, especially if you're sitting. Or clenching your fists can have slight effect. General strategies. It's interesting how many articles I've read about this and how many are based on really inadequate research. So you might be careful. Some of the advice you read is not based on very solid research. I've seen a lot that say you should sleep in a bed where your head is raised like 10 to 20 degrees or so many inches. But in fact, there's very little evidence that it works unless you tilt the bed so high that you slide out of it. And again, you might try it and see if it works with you putting blocks under the head of your bed. But unless you move your head of the bed up 16 inches, I think it was, it's not likely to have a significant impact. Another, there it is. I've also read a number of articles about wearing compression abdominal binder or compression pants, compression socks. According to some of the best research I've seen, it's really only effective when you wear an abdominal binder, and only then when you're changing position from lying to standing. It's not helpful to wear it all day. So Dr. Goldstein, I think, was one who said that other in addition. So he says, don't waste your money on compression stockings, pants, etc. There's little evidence to suggest their use. Other non-pharmacological measures. Oh, this one is really good, really important. You should take, I think I have a typo, up to 2 liters of water a day. Make sure you drink 2 liters. That's a lot of water, but I drink 2 cups at a time, and that really helps. I think that's one of the most helpful things for me, especially before I exercise, and I can guarantee you it makes a difference in my heart rate and my blood pressure. Let's see. Salt is also recommended. Oh, I know the 2 cups is really important, because when you take 2 cups of water, it stimulates the sympathetic nerves to act. And that means what little bit of sympathetic nerves you may have left in your heart may constrict your heart, constrict your arterioles, and help that blood that's in your heart to pump up to your brain, and to actually help you get through that exercise routine. Or if you're going to the store or a wedding and you know you have to stand for a while, take a bolus of water, 2 cups within like 3 minutes, and it will help to sustain your blood pressure for about an hour. So I also just am listing here for your benefit some of the medications that are recommended for treatment of orthostatic hypotension. And some of these are more highly recommended than others. And you might just have to try a number of them before you find a combination that helps you. So in summary, let me just remind you what my thesis was. Neurogenic orthostatic hypotension is a common, deadly, disabling, non-motor disorder of Parkinson's disease that has a huge impact on our quality of life. It's often overlooked, misdiagnosed, and undertreated. And education is critically important. Teaching Parkinson's patients how to measure their own orthostatic blood pressure at home, keeping a log, and discussing results with your doctor may become an opportunity to request a 24-hour ambulatory monitor and draw attention to the possibility of a neurogenic orthostatic hypotension diagnosis. And it may save you many years. So thank you for this opportunity. Any questions?
I think Libby.
We didn't have any questions come through chat, but please put your questions in as they're coming to you now that she's completed. I wanted to clarify, when you are checking your blood pressure, did you say that you should be lying down for about 5 minutes? So nice and quiet, lying down for about 5 minutes before you check it?
If I didn't say it, I should have.
Okay.
Yes.
Okay, very good. So even at your doctor's office, when they've done that for you, they tell you to lay still and rest. We'll be back to check your blood pressure, right?
Well, they should.
Okay. Oh, someone said that they sent a question directly to you, Jean. Do you happen to see it?
Hang on.
Let's
We'll go
see.
right here.
Maybe you'll just need to retype that if she can't find it.
Let's see.
About carbidopa levodopa.
Oh,
So there's one is
is it a potential
trihexyphenidyl.
source? You know, I don't know that medication, but there are a number of medications that you can look up that help to cause orthostatic hypotension. A medication can't cause neurogenic orthostatic hypotension.
Okay.
So there's a big
So-
difference.
Carbidopa, levodopa is the generic for Cinemet.
Yes.
Yeah.
Levodopa can help to cause your blood pressure to fall. Levodopa cannot give you or cause neurogenic orthostatic hypotension. That is only caused by your nerves, by the autonomic nervous system. That help?
Yeah. So you might have other questions that people may have sent directly to you because I'm not seeing anything.
Okay.
We're
Just-
not.
You're not
didn't-
seeing anything.
it
I
just-
was- I was wondering whether the drinking of the 2 cups of water,
Mhm.
is it recommended that, does it matter what temperature? Like if you drink ice cold water versus hot water?
Doesn't matter the temperature, but they do recommend it just be water, not tea, coffees, juice, soda. Water by itself causes that sympathetic response,
Not Gatorade?
not
or-
Gatorade. Now, you might want to take Gatorade in addition because it has some salt in it and sugar, but primarily you need to increase your salt intake, they say. And the amount that you drink total should be at least 2 liters a day. But if you want that bolus, you want that benefit quickly of not feeling dizzy when you stand up when you're going shopping or something, that bolus of 2 cups really does make a difference, and you have to drink it quickly. I must add, it is difficult for me to do that. When I wake up in the morning, I don't want to drink 2 cups of water to go exercise. My stomach feels like it's sloshing around in there, but it does make a difference. So I'm tolerating it. The payoff is worth it. I think there were some questions Nancy had sent me earlier.
That made me think about a question then for Nancy as a exercise instructor. And you were talking about if there's not good sympathetic nerves in the heart, people can have trouble with exercising.
Yeah.
So what is that? So sometimes we tell people to pay attention to their heart rate on their Fitbit when they're exercising. So how does that play out?
The heart rate, I didn't mention that, but when you take your blood pressure, you really want to take your heart rate as well, because it responds to the fact if your heart rate is dropping, if your blood pressure is dropping, your heart will try to compensate by pumping harder. So typically your heart rate goes up in compensation. But with this disorder, your heart rate that may start pumping a little bit more, but not nearly enough to compensate. But what I thought you were going to ask is, with exercise, what might be good to do to keep this from happening during exercise? Because quite often the stress that I find, what happens to me, the stress of exercising causes my blood pressure to gradually drop, even with my water bolus. So after about a half hour, my blood pressure is low enough that I sit down to facilitate oxygenation, blood flow getting to my brain. So I think Dr. Dibble, who spoke 2 weeks ago about exercise and dysautonomia, was suggesting that you exercise at a low position and gradually get higher, like don't combine standing exercises with then things where your head is real low, jumping with your head low and then high, because then that makes it harder for your body to compensate continually, adapt to maintain your oxygenation in your brain. Other things, there was something, I can't remember. I read a couple of the questions earlier yesterday or today, but I can't remember now. But I hope you all will think seriously about measuring your orthostatic blood pressure. Is somebody talking?
No, thank you.
You're welcome.
It was so well explained, Jean. You did a fantastic job. And I'm so glad that we recorded it, so
you.
that people can take advantage of this information that's not well known. And the recordings for the other programs are also up on our YouTube. So if you missed Dr. Goldstein or Dr. Dibble's presentations in our first 3 parts of the series, they're up there.
I also wanted to suggest that you might want to look at the bibliography. I put a lot of the references that I used in the bibliography, so that there's a lot of good resources there.
That's good. We'll send out Jean's slides, and I'll send the YouTube link with the for how to find the recording, which is where you can also find the other 3 as well, probably on Monday or Tuesday, depending on when I get the recording back. So.
Okay, someone said that they did send a direct question, but I'm sorry, I wasn't seeing it. Kim, if you want to type that in real fast, to type it to everyone, and then we know for sure that we won't lose it.
Yeah, we only have directly 2 questions.
Maybe she sent it to me, to my email.
She says she sent it to Nancy. Oh, well, yeah, that won't work, Kim. Nancy's not on a separate,
I'm
Oh,
on Jean's.
not in front of the computer where that's going.
okay.
What about SATs?
SATs, O2 SAT.
SATs, I think is probably what she means.
Well, quite often the O2 SATs are normal, even though your blood pressure is extremely low. At least I have found that to be true. I can be breathing really heavy and my O2 SATs are staying up there, but it doesn't mean it's not doing damage, unfortunately.
Okay. Well, it is after 3 o'clock.
Very good.
So thank you.
Thank you.
Thank you.
Great.
Thank you.
All right.
Super.